diagnosis of ground glass opacities. Just have a okay. This is let's have a review on the anatomy of the Scandi lobules. Here you can see that this structure shows that this is Scandi lobule supplied by a blue-shaped pulmonary artery, and this is bronchogram. This is bronchus, branches of the bronchi, and this red one is the pulmonary vein supplying this central lobule. And this central lobule is surrounded by lymphatics. This yellow colored are lymphatics, right? This is very important to understand that all those diseases which spread through the blood, they will present as central lobular nodules, and all those structures which spread through the lymphatics, they will be present as intralobular septal thickenings. That this is the intralobular. This is one lobule, sorry. This is one lobule and this is second lobules. And this is the intralobular septal thickening. If any disease spreads through the lymphatics, there will be thickening of these lymphatics, and you will have septal thickening. Like pulmonary edema can present like that, sarcoidosis can present like that, and lymphangitic spread of the tumors can present like that. So these are the normal sizes which are shown here. That this is interlobular septa. Its thickness is 0.1 mm. When it is more than 0.1 mm, you say that septas are thickened. See, it's important. Okay, this is the basic anatomic unit of structure and function. It is supplied by small bronchiole, artery and a vein, surrounded by connective tissue septa. It measures about 1 to 2 centimeter. And pulmonary veins and lymphatics, they run in the periphery. Under normal conditions, only a few of these very thin septa will be seen. Isolated finding of interseptal thickening is of no importance. It is important for understanding of interstitial lung diseases. Okay, you have different schemes when you review HRCT chest. First of all, you see what is the dominant pattern. It is reticular, nodular, reticulonodular, it is ground glass haze or whatsoever. Then you see that what is the distribution of these findings in the Scandi lobule, whether it is central lobular distribution, it is random distribution, or it is perilymphatic distribution. Then you see what is the distribution within the lung, whether it is dominant in the upper zone, lower zone, or peripheral or central zones. Okay. Then interlobular septal thickening, it can be irregular, it can be smooth and nodular. If it is irregular and there is associated lung distortion, you see honeycombing, then your differentials are interstitial lung diseases. If interlobular septal thickening is smooth, I will tell you that what are the differentials. If interlobular septal thickening is nodular, it means that the disease process is being spread through the lymphatics. Then your differentials are sarcoidosis and lymphangitic spread of the tumor. If you have smooth interseptal thickening, you see that whether it is ground glass predominant or it is not ground glass predominant. If you see that there is interseptal thickening which is smooth and it is associated with ground glass haze, this picture is known as crazy paving. And if you see that there is interseptal thickening and there are no ground glass haze, then you say that this patient can have pulmonary edema, hemorrhage or amyloidosis, lymphangitic spread of the tumor. But remember, in all these conditions, there can be ground glass haze, but interseptal thickening will be more obvious. Here you see that there are interseptal thickenings which are localized in this upper region. You see that this is the septal thickening, this is the septal thickening, and this is the septal thickening. It shows that this patient has LIP, is lymphoid interstitial pneumonias, and the differential diagnosis is it can be lymphoma, it can be LIP. This is irregular septal thickening, and how you would differentiate it from sarcoidosis. Sarcoidosis is bilateral, and pulmonary edema is also bilateral, and in pulmonary edema you will find an increased heart size. Here you see that there is ground glass haze, but predominantly you see that there is interseptal thickening, right? So this slide shows that this patient has pulmonary edema. Here you see that there are multiple septal thickenings, but these septal thickenings are not smooth. This is the septal thickening, this is septal thickening, this is also septal thickening, this is septal thickening, this is septal thickening, and this is septal thickening. But you see that these septas are not thickened smoothly, they are nodular in pattern, and this type of the picture suggests that this patient may have sarcoidosis.
This one, you say this starts from the periphery, but this looks like from the center or side.
Look. This
But
is,
arrow one was
but it is spreading towards this periphery. It's going towards this periphery. Look,
बेसिकली वो जो है ना सेप्टा और वेसल में जो डिफरेंशिएट करते हैं
वो मैंने वो
वेसल
आपको
पेरिफेरी तक नहीं जाती तो सेप्टा है वो पेरिफेरी तक जाते हैं
वो
लेकिन ये क्योंकि एक स्लाइस है ना तो जरूरी नहीं है कि वो एक ही लाइन आपको पूरी आखिर तक नजर आ रही
अच्छा इधर देखो ये जो है ना ये देखें नोड्यूलर है, ये एक नोड्यूल है, ये दूसरा नोड्यूल है, ये तीसरा नोड्यूल है, फिर आप इसमें देखें ये सेप्टा थिक है, ये भी स्मूथ थिकनिंग नहीं है, इधर से देखें ये भी स्मूथ थिकनिंग नहीं है, ये आप देख रहे हैं ये स्मूथ थिकनिंग है, ये भी नोड्यूलर है।
सेप्टल थिकनिंग है और रैंडम नॉड्यूलरिटी है, आपको सेप्टा के साथ भी मिल रही है और वैसे भी
मिल रही है आपको। So this slide shows that this patient may have sarcoidosis. Okay. What you see here, you see that there are interseptal thickenings, but predominantly there is ground glass haze. Here you see that the septas are thickening smoothly, that this is the septal thickening, and this is smooth pattern associated with ground glass haze. So this type of picture is known as crazy paving. There are differentials of crazy paving. The most important is alveolar proteinosis, and that's PCP pneumonia, and then sarcoidosis, NSIP, POP, and ARDS. Can you identify this pattern? There is septal thickening, there is ground glass haze, and now you have to identify whether this septal thickening is smooth or nodular. If it is smooth and this is ground glass haze, this picture suggests that this patient has crazy paving. And the differentials are same that I told you in the previous slides. This is crazy paving. Okay. Now come to the nodules. There is a distribution of the nodules. If some nodules are distributed along the lymphatics, they are known as perilymphatics, and this is the feature of sarcoidosis and lymphangitic carcinomatosis. And if the nodules are distributed randomly, they are not equidistant from each other, and they are present on the periphery as well and in the center as well. On the periphery, just adjacent to the pleura, these nodules are randomly distributed nodules, and if the nodules are present equidistant from the periphery of the lung, almost 5 to 10 mm from the periphery, equidistant from each other, these are known as centrilobular nodules. This is one lobule and this is nodule. This is one nodule in the scanty lobule. This is another nodule. So if you see many nodules present in the slide and those nodules are equidistant from each other, you say that this patient has centrilobular nodules. Here you see that this patient has many lot of nodules. These nodules are equidistant from each other, so this patient has centrilobular nodular pattern. Typically around the small airways and spare the subpleural surfaces, they are typically at least 5 to 10 mm away from the pleural surfaces. Here you see that there is a nodular pattern, but this nodular pattern is present along the lymphatics. This is perilymphatic nodular pattern, and this suggests that this patient may have sarcoidosis. Perilymphatic nodules in relation to lymphatics, they are subpleural nodules, peribronchovascular nodules, septal nodules, and patchy distribution. But you see that this is the interseptal thickening, and this interseptal thickening is nodular. So the differentials that comes to your mind is sarcoidosis and lymphangitic spread of the tumor. Again, this slide shows that this patient has perilymphatic distribution of the nodules. This is a slide suggesting sarcoidosis. Now come to the centrilobular nodules. These nodules, they are present all over the slide and they are equidistant from each other. They are not distributed along the lymphatics, and they are not randomly. They are equidistant from each other. So all these nodules are centrilobular nodules. This is subacute hypersensitive pneumonitis. What you see here, there is interseptal thickening and there is a bit ground glass haze, and you see that there are multiple nodular patterns. All these nodules, they appear to be equidistant from each other. So this slide shows that this patient has subacute hypersensitive pneumonitis. In subacute hypersensitive pneumonitis, it spreads through the blood vessels, and there are some nodules which are present in the scapular lobule.
This is reversible or irreversible?
HP.
Yes.
Okay. You don't see any honeycombing, so this is reversible. Yes.
Minus of exposure, history wise, कभी आप ग्राउंड सेज होगा या क्यू सेज होगी सब कुछ वही करके element of atrophy now.
Okay, what you see here, that this is interseptal thickening, this is the interseptal thickening, this is the septal thickening, and this is the septal thickening, this is the septal thickening. Overall, you see that there is ground glass haze, and you find that there is sign of air trapping. This is air trapping, this is air trapping, this is the air trapping, and this is the air trapping. This is air trapping. Actually, what happens in hypersensitive pneumonitis? In hypersensitivity pneumonitis, the patient has bronchiolitis obliterans. When you get an expiratory scan, the air is trapped behind the obstruction. So when you get CT, you find and it's signs of air trapping. Ground glass haze, it shows that patient has an inflammation, and interseptal thickening shows that this patient has some interstitial involvement as well. So this combination of air trapping, ground glass haze, and interseptal thickening is known as Hrct sign. This is a feature of hypersensitivity pneumonitis.
Hrct sign और crazy paving में कैसे differentiate है?
Hrct sign में भाई उसमें ना predominantly जो है वो होता है जो ये देखें ना, इसमें predominantly देखें, इसमें predominantly ground glass haze होता है, ठीक है, और smooth septas होते हैं. हाइपरसेंसिटिव pneumonitis में भी आपको सेप्टल थिकनिंग मिलेगी, ग्राउंड ग्लास, मगर उसमें एयर ट्रैपिंग वो होती है. आप उसमें एक्सप्रेटरी स्कैन कराते हैं तो आपको कंफर्म हो जाता है.
नहीं, इसमें भी आप देखो ना कि एयर ट्रैपिंग तो है इसमें,
मगर ये देखें हाइपरसेंसिटिव pneumonitis में जो एयर ट्रैपिंग है वो एक्सप्रेटरी स्कैन करते हैं तो आपको कंफर्म हो जाता है दैट दिस पेशेंट हैज अ हाइपरसेंसिटिव pneumonitis. ये उसका डिफरेंशिएटिंग पॉइंट. Okay. This slide shows that this is tree and bud appearance. Centrilobular nodules interspersed with linear and branching densities. It is then termed, this is tree and bud appearance. This is tree and bud appearance. This is usually present in the periphery. This is tree and bud appearance. See भाई ये भी तो tree and bud है.
ये characteristic
ये tree and bud appearance. There can be some infective causes and there can be some non-infective causes. In infective causes, you should remember tuberculosis and fungal infections, and then non-tuberculous mycobacterium. And in non-infective causes, patient can have cystic fibrosis or bronchiectasis.
Commonly when we say endobronchial spread of infection.
Endobronchial. Again, this is tree and bud appearance. This is tree and bud appearance. There are some differentials of perilymphatic distribution of nodules. It can be present in pneumoconiosis, silicosis, all forms of interstitial lung diseases almost. And centrilobular nodules are present in hypersensitive pneumonitis, and all those diseases which spread through blood, like tuberculosis, bronchoalveolar carcinoma, Sturge-Strauss syndrome, respiratory bronchiolitis in smokers, and infections. What do you see here? What does this slide shows? This is perilymphatic distribution of the nodules, right?
ये lymphadenopathy
और ये lymphadenopathy है, ये sarcoidosis है. These are randomly distributed nodules. You see there are a lot of nodules, and these nodules are not uniformly distributed. This is miliary tuberculosis, miliary fungal infections. Sarcoidosis may also mimic like that Langerhans histiocytosis at its earlier stage. Clutch. Okay, this is the summary. When you see multiple nodules, you see that whether there are some pleural nodules. If there are pleural nodules, whether they are subpleural or diffuse. If they are subpleural, perilymphatic distribution, the diagnoses are white. If there are pleural nodules and diffuse, no predominance, randomly distributed, you think of TB, biliary infections. If there are multiple nodules but pleural spared, you think of centrilobular nodule distribution. Because they are 5 to 10 mm away from the pleura, na? So these are centrilobular distribution. Then there are some differences I have told you in the previous slide. This is perilymphatic spread, right? These are centrilobular nodules, these are randomly distributed nodules, and these are perilymphatic distribution of the nodules. Now, lobar ground glass
No
opacity.
important.
हैं?
हाँ ये लो बात
ये important है, अच्छा. Now there is predilection for certain lobes in different type of diseases. There are few diseases which are present in the upper lobes, and we remember the formula. The formula is cassette P, C for cystic fibrosis, ankylosing spondylitis, sarcoidosis, silicosis, and then eosinophilic granuloma, and then tuberculosis, and P for PCP, cassette P. And the basal distribution is present in rheumatoid arthritis and many drugs. ठीक है, अपर जोन्स में फिर ये आते हैं, बस यही है इसमें. Okay. What are ground glass opacities? When the alveolar air is replaced by pus, fluids, hemorrhage, inflammation or tumor cells, you get ground glass opacities. Thickening of the interstitium or alveolar walls below the spatial resolution of the Hrct as seen in fibrosis. If ground glass opacities are present in upper zone, respiratory bronchiolitis or PCP, they are present in lower zone, you should think of UIP, NSIP. Centrilobular distribution is present in hypersensitivity pneumonitis or respiratory bronchiolitis. Okay, this is ground glass haze. If it is acute, you should think of edema, hemorrhage or pneumonias. If it is chronic, you should think of hypersensitivity pneumonitis or NSIP or alveolar proteinosis. Can you identify this abnormality? This is abnormal. Okay. Interstitial involvement can be reticular, reticulonodular, or linear. What is the reticular pattern? Reticular, whenever the interstitium is involved, whether it will be reticular, linear, or it will be reticulonodular. If it is reticular pattern, it may be fine, it may be medium, it may be coarse. Mosaic लिखाऊं? मैंने skip कर दिया. बताओगे? Mosaic attenuation. The term mosaic attenuation is used to describe density differences between affected and non-affected lung areas. There are patchy areas of black and white lung. The role of the radiologist is to determine which part is abnormal. When ground glass opacity present as mosaic attenuation, consider infiltrative process adjacent to normal lung appearing relatively dense adjacent to lung with air trapping, hyperperfuse lung adjacent to oligemic lung due to chronic thromboembolic disease. Okay. Infiltrative process adjacent to normal lung, a normal lung appearing relatively dense adjacent to lung with air trapping. So whenever you have mosaic attenuation, you can have pulmonary embolism, you can have hypersensitive pneumonitis, or you can have some other infiltrative process adjacent to the lung. Okay. It can be difficult to distinguish these three entities. There are two diagnostic hints for further differentiation. You should get expiratory scans for air trapping. If you get expiratory scan and still there is an air trapping, this suggests a patient has hypersensitivity pneumonitis. Then you look at the vessels. If the vessels are difficult to see in the black lungs as compared to the white lung, then it is likely that black lung is abnormal. Then there are two possibilities. If the black lung is abnormal, then there are two possibilities. Either this patient has BOOP or this patient has chronic pulmonary embolism. Sometimes these can be differentiated with an expiratory scan. You get an expiratory scan, and still if there is air trapping, the diagnosis is BOOP. And if you get an expiratory scan and there is no air trapping, the diagnosis is chronic pulmonary embolism. If the vessels are same in the black lung and white lung, then you are looking at a patient with infiltrative lung disease, like the one on the right, like I show you. Thus, you see that there are vessels present in the white lung and in the black lung. This is a feature suggestive of diffuse alveolar hemorrhage.
Now talking about next week.
इधर आगे चलें।
दूसरी काम किया ठीक है
ये देखना आप क्या होता है। ये देखिए, ये वाइट लंग है, इसमें भी ब्लड वेसल्स है। ये जो ब्लैक लंग है, इसमें भी ब्लड वेसल्स है। दोनों में ब्लड वेसल्स प्रेजेंट है। इसका मतलब हमको इन्फिल्ट्रेटिव प्रोसेस देखना है। ठीक, तो ये है डिफ्यूज एल्वेओलर हेमरेज। अच्छा, इसमें ये ब्लैक लंग है, ये इसमें वाइट लंग है। ये ब्लैक लंग है, ये वाइट लंग है। हमने ये अगर फर्ज करें, ये एक्सप्रेशन के ऊपर कराया हुआ है, ये एक्सप्रेशन पे कराया हुआ है। अगर एक्सप्रेशन पे करवाने के बाद भी एयर ट्रैपिंग मौजूद है तो दिस इज ब्रोंकियोलाइटिस ऑफ प्रीटी लैम्स, हाइपरसेप्शन न्यूमोनाइटिस। अगर ये हमने ये एक्सप्रेशन पे, ये फर्ज करें एक्सप्रेशन पे कराया है और इसमें हमें, जैसे इसमें देखें ना, हमें इसमें वेसल्स नहीं नजर आ रही ना ब्लैक लंग में, इसका मतलब ये ब्लैक लंग जो है ये नॉर्मल है। तो इसका मतलब ये है कि ये पल्मी एम्बोलिज्म का सीटी है। आप एक्सप्रेशन पे करा लें, अगर एक्सप्रेशन के ऊपर ये ब्लैक पोर्शन डिसअपीयर हो जाता है, इसका मतलब ये पल्मी एम्बोलिज्म है। अगर ये एक्सप्रेशन के ऊपर ब्लैक पोर्शन परसिस्ट करता है तो ये हाइपरसेप्शन न्यूमोनाइटिस है। ठीक हो गया?
नहीं, नॉर्मल सीटी करवाएंगे। नॉर्मल सीटी में अगर आपको इस तरह एटीन्यूएशन का पैटर्न मिल रहा है ना, तो इसका मतलब ये है कि या तो वेसल की एब्नॉर्मलिटी है या एयर ट्रैपिंग है। आप इन दोनों को डिफरेंशिएट करवाने के लिए एक्सपायरेटरी फिल्म करवाएंगे और उसके अंदर फिर देख लेंगे।
फिर देख ले, अगर एयर ट्रैपिंग खत्म हो गई है तो एम्बोलिज्म है, क्रॉनिक पल्मी एम्बोलिज्म है। अगर एयर ट्रैपिंग मौजूद है तो ब्रोंकियोलाइटिस ऑफ प्रीटी लैम्स।
आगे करना, इसकी डिस्क्रिप्शन दी हुई है।
ये देख, ये देख, ठीक हो गया? अच्छा, दिस इज हनीकॉमिंग। अच्छा, रेटिकुलर पैटर्न्स जो है वो फाइन भी होते हैं, मीडियम भी होते हैं, कोर्स भी होते हैं। जो फाइन होते हैं ना, इसमें ये ग्राउंड ग्लास हेज आता है फाइन में। ये बेसिकली मैं आपको ना उसकी इंटरस्टिशियम की इन्वॉल्वमेंट बता रहा हूँ। ये जो मीडियम टाइप का होता है ना, हनीकॉमिंग के 3 to 10 mm होता है, इसे कहते हैं ये हनीकॉमिंग है। जो कोर्स होता है ना, उसमें साइज मोर देन 10 mm होता है, वो बड़े बड़े नजर आते हैं। ये सिस्टिक शैडोज होते हैं, ये सिस्टिक शैडोज होते हैं। आगे मैं दिखाता हूँ। तो सिस्ट के अपने डिफरेंशियल्स हैं। पल्मी लैंगरहैम सेल हिस्टियोसाइटोसिस में होती है, सिस्टिक ब्रोंकाइटिस में होती है, लैम में होती है, पीसीपी सार्कोइडोसिस, बर्ड हॉक ड्यूब सिंड्रोम, एमुलेडोसिस। ये देखिए, बड़ी बड़ी सिस्ट नजर आ रही है। ठीक, ये अभी सिस्ट बता रहा हूँ, ये सिस्ट है, सिस्टिक ब्रोंकाइटिस है। ये देखिए, ये आपको बड़ी बड़ी सिस्ट नजर आ रही है। ठीक है, बड़ी बड़ी सिस्ट है, हाइपरइन्फ्लेटेड लंग्स हैं। क्या डायग्नोसिस बना? इसको लैम है।
लैम कैसे बना?
लैम है ना भाई, ये देखें, जब सिस्ट यहाँ पड़ी हो ना,
कॉस्ट ऑफ फ्रेंडिक एंगल है ना,
Cost
उसकी
of
अगर
friend-
स्पेलिंग ना हो
तो लैम है। अगर स्पेलिंग हो तो क्लच है,
क्योंकि वो अपन लूप हो जाता है। सर जी सर साइज का तो इसमें लैब में हो गई है।
नहीं मतलब एक्सेंट्रिक सी और वो शेप जो है ना,
एक भी शेप का
ज्यादा सा स्पेलिंग और नॉड्यूलैरिटी का फर्क होता है कि जो लैंगरहैम सेल्स है ना, उसमें नॉड्यूल्स होते हैं और कॉस्ट ऑफ फ्रेंडिक एंगल है ना, उसकी स्पेलिंग होती है।
रेटिकुलोनोडुलर पैटर्न हमने डिस्कस किया। वो पेरिलिम्फेटिक डिस्ट्रीब्यूशन जो है वो रेटिकुलोनोडुलर पैटर्न होता है। फिर ये लीनियर पैटर्न है, ये इंटरस्टिशियल, जिसमें आपको स्मूथ सेप्टास मिल जाए, वो इंटरस्टिशियल पर जिसमें आप कहते हो ये लीनियर इन्वॉल्वमेंट है। Now, what is the HRCT criteria for the diagnosis of UAP? First of all, I will tell you some features which are inconsistent with the diagnosis of UAP. One is the upper or mid lung predominance, because UAP is predominant in the lower zones. Then peribronchovascular predominance is against the diagnosis of UAP. This suggests that this patient has sarcoidosis. Extensive ground glass abnormality It is also against the diagnosis of UAP. Profuse micronodules bilaterally predominant in the upper lobes, against the diagnosis of UAPs, against the diagnosis of UAP. Discrete cysts, they are not present in UAP, and then diffuse mosaic attenuation and consolidation. So these are few features which are not present in UAP. Then the possible UAP pattern, there is subpleural involvement, basal predominance, reticular abnormalities, absence of features, which I have told you in the previous slide. If these are all are present, this patient has possible UAP pattern, and the definite UAP pattern is subpleural involvement, basal predominance, reticular abnormalities, honeycombing, with or without traction bronchiectasis, and absence of features inconsistent with UAP. Okay, what do you see in this slide?
UI.
Subpleural.
Do you think that this patient has subpleural involvement and basal predominance? Okay, one. Do you think that this patient has reticular abnormality?
Yes.
This patient has interseptal thickenings. This patient has interseptal thickenings. This is reticular abnormalities. Honeycombing?
Yes.
Any feature which is inconsistent with UIP pattern.
No.
So what is the diagnosis? This is usual interstitial pneumonia. There is subpleural basal predominance. Do you think?
No.
Any reticular abnormalities? Honeycombing?
No.
Any feature inconsistent with UIP?
Yes.
There is a ground glass haze, and this is traction bronchiectasis. Traction bronchiectasis is a feature of NSIP. You find ground glass haze. So this slide shows that this patient has NSIP.
Sunday यहाँ पर traction bronchic.
ऊपर भी है.
ये है traction.
बस खत्म हो गया. सिस्ट भाई सिस्ट नहीं है. सिस्ट वही थी जो मैंने दिखाई थी शुरू में.
बहुत वैसे